Today we will see this video which explains how to easily explant a foldable IOL when it is needed to be done so. Now this is all an individual with some emulsified oil and deposits on the surface of the IOL which made the IOL little opaque and compromised the vision. So we needed to explant this IOL and exchange it with a new IOL. And just like a canny cataract surgery, you will need to make two ports. Prolapsing the IOL out of the bag, we can also see that there is a YAG laser capsulotomy present. So that makes the situation a little tricky. The IOL has been explanted out of the bag. One of the haptic is out, and the other haptic also needs to be dialed out. Now this surgery is being done under topical anesthesia, which is sufficient to provide a painless experience to the patient. Once we have the IOL which is out of the bag, then we can proceed for the next step. Now this requires that one of the haptics has to be prolapsed out of the main wound, which is measuring 2.8 to 3 mm in size. Once this haptic is prolapsed out, then what we need to do is hold this haptic and the edge of the optic, and it is important not to hold the center but rather the stalk which is attached to the optic part, and keeping a dialer above it and pronating the wrist so that the IOL bends or rotates upwards. The dialer above it will keep it in a situation that it will make it fold and be prolapsed out of the eye. Now this is an in vitro practice and demonstration of the same situation and how it can be done inside the eye. We can see the same thing in the slow motion so as to understand what is going on. There is hypotony. Viscoelastic gel can be used to replenish, and the aim is to implant the replacing IOL in the bag so that it is in the most physiological situation. The IOL leading haptic and optic has gone into the bag, and now dialing rest of it into the bag again so that the IOL rests properly. And it's interesting to know that if the IOL is not implanted in the bag, the resulting effect may have an unpredictable refractive surprise. The chamber is formed, IOP is fine. This is the explanted IOL, and zooming in into the IOL optic, we can see that the central area has got some kind of deposit which is making it irregular in refraction and pigmented brown. Now this patient was doing fine, and next day the vision was 6/36, which was good enough considering the patient also had some other retinal issues as he has been operated for a retinal detachment. Thank you.